huge announcement about registering for Summit and some details, which is really nice. And since it came from her section, I don't know if it pinged to your phone or not, or wherever, so go look at that. All right, so it's out there. I went in student view to make sure you can see it, so that's why I'm telling you. So I'm your teen on your phone, okay? So it's just some information her students were asking her. She goes, "You want it on your site?" I said, "Yeah." So anyway, and when it comes that direction, sometimes you may not think to look because it may not ping your phone. The other thing, I guess after y'all left, it was probably 5 o'clock or later. Ms. Robichaud sent this. She told me to put an announcement on my site, and I didn't think it was necessary. I thought I'll just walk in there and tell them. I don't know why. Don't ask me why. We can't put drinks and food items in the trash in the bathroom anymore. So if this trash can gets full, let a faculty member know or let the housekeeping people know, and we'll just have to empty it. Okay? We'll have to get us another bag. So keep all the food for the rats in here with us, rats, which is fine with me. We'll get it taken care of, okay? Just please don't put any drinks or food items in the bathroom trash. The other thing I wanted to make sure to tell you is I have been working trying to get these projectors fixed. I've had the people in here, you may know, we don't know if he knows. Oh my great! We don't know if he knows the resolution or not. But we're working on it, and I apologize. So today we're going to roll through. I've written a few things on the board that I don't know that you're going to read. And so I've just kind of made myself a note to push you to it. And so we've been talking, what I do, I start talking in general about some of the cardiac disorders that you've already covered, either in LPN or level 2. So we've already talked a little bit, and we're going to mull through that PowerPoint this morning about unstable angina. That's what UA is over here on this board. And we talked a little bit about heart failure, which is the HF. For some reason, it's real easy to get those labs mixed up. So I need you to truly get those divided in your head. When we're looking at, when a patient comes into the ER short of breath, and we don't know what is wrong with them because they have everything. They have every disease process or comorbidity. And we're going, why are they short of breath? They smoked for 20 years. They could have pneumonia. They could have a lung issue going on. But they also have a history of heart failure. So what we'll do is draw a BNP. And if it's extremely elevated, we kind of know real quick that shortness of breath is coming primarily from the heart. Now, there are other clinical findings that we would know as well if it was heart failure. We would hear crackles. If it was a lung issue, we would hear wheezing. And so, we talk about things in cups almost, like in categories. But our patients present, and they don't have on them what's going on with them, so we have to figure out which category to treat first. Does that make sense? Mm-hmm. Okay, but since we're studying the heart, if I say heart failure, you say BNP. And a normal BNP is less than 100. Very good. And the larger the number, the more fluid. Okay, and it's getting better when that number comes down. Very good. And we don't draw a BNP very often. We don't even do it every day. So I just want you to know, that's not something you would be repeating very often. If they just check it to see what's going on, and then once the patient's treated, they'll check it again to see if they're better. Make sense? Okay, and now MI, unstable angina, if we're trying to determine between those two. And there's another category. I could actually break the MI down to STEMI and NSTEMI. So, but if a patient comes in with chest pain and we're trying to determine if they are in that umbrella of acute coronary syndromes, the lab we're going to draw is enzymes, that panel of enzymes, cardiac enzymes. And so get that straight in your head, because I'll see test questions all the time, and you will select the wrong one. And you'll say, well, it's all heart. So I just figured, no. When we're looking at heart failure, it's BNP. When we're looking at acute coronary syndromes, whether it's unstable angina or MI, we're looking at CKMB troponin primarily. There's one more in that panel sometimes at certain facilities, and that would be your myoglobin. Okay? But primarily, to be current, they're doing a lot of troponin. We don't do a whole lot of the others, but we do panels, because if we're going, is it an MI? Or is it just chronic something else? We're looking for a peak in those enzymes over hours. That's how we know the difference. Do y'all remember that? So the deal here is timing. And I hope you remember that. And so how do we determine, I got a question for you, so I want to know if you remember this. How do you determine if it's an NSTEMI or a STEMI?
One can be seen on
All right, what tells you,
ST segment elevation.
all right, so, do y'all agree with Kelsey? STEMI is EKG evidence. Y'all with me? How do you know someone's had an NSTEMI?
Their troponin is elevated.
It's a lab evidence. Alright, so how do you tell the difference between an NSTEMI and unstable angina? Because they might both show signs of ischemia on the EKG, such as ST depression, T-wave inversion. So how do you know the difference between an NSTEMI and unstable angina? Lab evidence. If it's just unstable angina, they're not going to have elevated enzymes. So this is just ischemia. On the EKG or clinical presentation. And what does that mean?
Signs and symptoms.
Signs and symptoms. Signs and symptoms. Because we know someone's becoming unstable in their angina if it's starting to become unpredictable. It's now unpredictable, it's lasting longer, and it's even starting to occur at rest sometimes. And there are definitions in your book of all the different types of unstable angina that the doctors will classify in their notes. You can read them if you want to. You will learn that as you go, but that's not something you would need as an entry-level nurse, so I'm not going to throw that on you. Some of those would be, if you're interested, don't write this down, it's not on your test. Like Prinzmetal angina, you may read that in a chart. You may read pre-infarction angina would be an unstable angina. The doctors will classify them. And the reason I'm telling you is every semester I'll have a student like Christina who will email me, oh my God, Miss Cooper, do we need to know Prinzmetal's angina? Do we need to know this? And that's a blessing that you've got somebody who I know is reading. So I'm like, yeah, go girl. But you don't need to know that unless you're really going to be working in that heart area. You know what I mean? If you are, you probably need to know it because they use that terminology. sometimes, and it can be kind of confusing if you don't know what they're talking about. So those are different types of unstable angina in your book. All right. So do you know the difference now? A little bit. Does that help clear it at all? Okay. Because you have to know that. Hint. Hint. So with the STEMI, we got EKG evidence, and that's a more serious heart attack involving a larger area of the heart, a STEMI is. Okay? And in-STEMI is not as significant, but it is significant, but it's not, there's not as much heart muscle damage. We don't see anything on the EKG with an in-STEMI as far as ST segment elevation. We may see with an in-STEMI, we may see some ischemia. What's ischemia on the EKG? I just told you, you tell me.
ST depression.
Or T-wave. Okay. So you can still with an in-STEMI have some ischemia, but you don't have a what? You don't see the infarct, but you may see some ischemia with an in-STEMI. I don't want you to, but we can tell the difference, hold on, we can tell the difference in unstable angina and in-STEMI because of the lab. That's the difference. And in STEMI, you still have, or can have, not necessarily will they have. I have taken care of a many patient that I did not see any changes in the ST segment nor the T wave, but they had clinical signs and symptoms. So we drew enzymes, and guess what? They had had an in-STEMI. All right, so you can have it either way. Questions?
Ischemia. What did you say what that was again? I missed it.
Ischemia?
ST elevation
No. Ischemia is ST segment depression.
and depression.
Yeah. Make sure you get that straight. And T wave inversion. And infarct is ST segment elevation. And I'll show you that. But something came to me this morning in the drive, and I thought, I don't know if they know the difference. So I want to make sure I put that on camera. Okay? All right. Well, let's get through with this cardiac testing. I like to visit what I have already talked somewhat about. Make sure you're very clear on some of the stuff I talked about before I move forward for the day.
I have a question about the stress test. You said they have to have 2 negative enzymes.
If they're an inpatient, to go for a stress test.
And because troponin T
And enzymes are,
an example of a negative number, because I'm confused. This might be another question.
oh, you've got norms on your lab?
So it'll be less than, that'll be the negative
Less than that number. It won't be negative. It'll just be that less than that number or that number.
Okay, that's what I was looking for.
Yes. Yes. All right. Pacemakers. Everybody. We pace primarily slow rhythms. You hear me? That's not the only thing we use pacemakers for. But 9 times out of 10, that's what they're for. Okay? We pace slow rhythms. Everybody understand? When I say slow, what's slow? Less than 60. And not just, we don't just pace them because they're less than 60. We put a pacemaker on people who have signs and symptoms, and what are those signs and symptoms of? Poor perfusion or cardiac output. So what are some signs and symptoms of poor perfusion or poor cardiac output? Chest pain or discomfort. What else? Real cool extremity. Dizziness. Modeling. Diaphoresis even. Altered LOC. Beautiful. Decrease urine output. So you see where I'm going with this? Okay, they feel bad, they feel horrible fatigue, they feel dizzy, and the one I hate to hear is, I just don't feel right. All of a sudden. I'm like, oh God. Oh, something else, but oh my, okay. All right, so I want to make sure, because we'll continue to cover this in level 4, and you see it's blue, too slow or bradycardic, right? So, and the other thing I want you to see is the word symptomatic. Do you see the word symptomatic? We don't just pace people who are in bradycardias. Because some people are in bradycardia and it's normal for them. Y'all understand that, right? Okay. So those are some of the reasons we pace people and some of the rhythms, and I'm not real interested that you know all that. We no longer pace asystole. Some of the older doctors are still a little stuck, and we have changed guidelines with ACLS. So current guidelines are we do not pace asystole. Now, am I saying you'll never see it? No. Is that, do y'all know what asystole is? It's flatline. It's absolutely nothing. There's no electrical activity there. But back in probably as much as 6 years ago, we were still pacing asystole. We were trying to, yes.
Oh, that's crazy.
So they would do it whenever someone was like dying, like
They'll
they're
just
dead?
try anything. They would just try anything. And so the science came back that it truly doesn't work, and so we don't do it anymore. All right, so we have to have something to work with, all right, electrically. We have something to work with. All right, so here's something I want you to get in your head at level 3 so that when I say it in level 4, you don't lose your mind. Stable people get medicine, or say stable symptomatic, because we don't just give medicine to anybody for no reason. Stable symptomatic patients get medicine. Unstable patients, and of course they're going to have symptoms, unstable patients get a form of electricity. Okay? So, if a patient has a bradycardia and they're symptomatic, then the doctor is going to say, are they stable? How do they look? And how are you going to know how to answer that?
Signs and symptoms. Like,
Assessment, but what in your assessment tells you someone's stable?
If they're holding it, like they're holding, they're not
Holding what?
fluctuating. Like they're not fluctuating. They're not like going
Holding what?
A baseline?
like a.
I'm trying to get you to, I'm trying to pull
Okay,
it out of you,
so
but let
like-
me give it to you, because we don't have a whole lot of time today.
They're
And
not
I'm-
going in and out of consciousness. Makes it a little bit easier.
Good.
If they're stable or not.
Yeah, let me give you an easy way on a test, and then I'll talk about a patient. On a test, the only way we have to give you is a description and a blood pressure.
Yeah.
And that's the reason that I want you to learn MAP, M-A-P, and I've got it's in this PowerPoint that I'm going to pull up in a minute, and I wrote it on the board too. You don't have to write it right now, okay? But if their blood pressure is really low, are they perfusing their major organs?
no.
No. So on a test, you can tell if someone's stable if their blood pressure is above 100 systolic. Right? If they're telling you their blood pressure is really low, like 80 over 40, or even worse, 70 over 30, is that patient stable?
No.
No. And their brain's probably going to start suffering, and all their major organs are going to start too. Does that make sense to y'all? And so all I'm trying to paint a picture of right now is 2 things. Decreased cardiac output. So if someone has decreased cardiac output, the amount of blood pumping out of their heart, they're going to have decreased perfusion. And so if they have decreased perfusion to their brain, they're going to have decreased LOC, perhaps some confusion, some dizziness. You with me? Pulses are going to be weak. They may even get real thready where you can't hardly feel them. So y'all getting it? Okay. So stable people, we have time. We have time. They're holding their own, as Kelsey said. They're perfusing their major organs and their brains still. So we have time to give them medication, right, for what's going on with them. So with bradycardia, I don't know if you remember from LPN school or level 2, the medicine we give for symptomatic bradycardia is atropine. Now, if the patient is unstable, poor perfusion, decreased blood pressure, they look like they're swirling that drain, we don't have time to be trying to draw up atropine or get atropine. We have a crash cart that has a shock box on it, don't we? A defibrillator box. Do y'all remember that? Shock box on the crash carts at the hospital on every unit, I hope. We didn't take it and replace it. So that shock box can do 3 forms of electricity. Super cool. It's all electricity. The one we're talking about is pacing. So that defibrillator box can pace a patient temporarily through the same pads that we shock with. That's called trans means through, cutaneous means skin, pacing. That is temporary. If I tell you it's electricity, do you think it hurts? Mm-hmm. It does. And you can actually, we put them front back when we pace, those defibrillator pads. And it makes if you put it up pretty high, you'll see it actually twinging their skin if you put it up really high. And sometimes we have to in order to get the heart to respond. Okay? So pacemakers, we pace what kind of rhythms?
Slow.
Slow or bradycardic rhythms, primarily. Everybody got that? That's what I want you to get this semester. Okay? We're going to finish this in level 4. All right. So I just talked about a temporary transcutaneous pacemaker, right? Now, does it make sense to you if the pads are front back and it's making motion over here on the left side because your heart's on the left side? Do not put your blood pressure cuff on the left side. You need to put your blood pressure cuff on the right side.
Can you repeat that? I'm sorry.
You don't need this for your test. I'm just trying to give you some good, helpful information. Common sense. If you've got a transcutaneous pacemaker on your left side, it's a little, do you know what the defib pads look like? They're little, they're square, they're about this big. And you take the back off like you take the back off of a Band-Aid, and you stick one here and one here. And we can either shock through those pads if the patient codes, just like the pads you used at CPR training with an AED.
Okay.
Okay? So if we've got the pacer pacing them through those pads on their chest, when we put the blood pressure cuff, we need to put it on the opposite side.
Okay.
Yeah. All right. We can't pace a patient very long that way. Does that make sense that they're going to get burned on their skin? And that's very temporary. So we need to be getting that patient to the intensive care unit, to the cardiac unit, and get them a more long-term solution, and one that is not going to damage the patient or hurt the patient. So why in the world, you're thinking to yourself probably, when will we only use a transcutaneous pacer? Well, let me tell you some of the times. We were talking about beta blockers and calcium channel blockers the other day, and we said it did what to the heart rate? So what if grandma also started having a little dementia, or she got an infection and got confused, and she took her medicine like 3 times? So she took her calcium channel blockers, her beta blockers, and her DIG. She just took it all about 3 times. And she comes to the ER because somebody finds her kind of unresponsive. And guess what? What are we going to do? She's unstable. She's still got a pulse, but it's about 30.
Spark it up.
Spark her up. So we're going to temporarily pace her. And she'll be sent to the unit because ER ain't going to keep you long. Nah, they do sometimes. And anyway, we've had this happen to us on the med-surg floor where the medicine had not taken effect yet. And they admitted the lady for something else. And all of a sudden, her heart rate was like 30. And we were like, what the heck? And so we paced her. And the doctor come in and we started asking questions to the family and said, go get her meds. And we figured out what she had done. So then we could give medications to reverse some of the meds she had taken and get them out of her system, do things to get them out of her system. And so we had her back at it, and she didn't need the pacemaker anymore. So there was no need to put any longer-term pacemaker in her. Does that make sense? So that'd be some of the reasons you would do that. So pacemakers can be temporary or permanent. Now, we can't be stopping every 5 minutes.
If you have an internal pacemaker
I'm going to get there.
and they code
Mm-hmm.
and then you shock them externally, does it won't work anymore?
They're dead anyway if you code them.
You ain't gonna get them any more, dude.
You can't get them any worse. So, I mean, it ain't going to hurt them. And if it does affect that, evidently their pacemaker, if that was the problem, is not working anyway. Does that make sense?
Okay.
Does that make sense? But that's a good question. I'm just y'all worried about our time because I need to get in that PowerPoint. And if there's something that you need to know or clarify with me, you have me after lecture. I never run out of here. And I do that on purpose because I know I might spark some questions. And you can email me. So I'm not trying to be that way. I just try to make sure we get through what you need for your test. That's all. All right? Okay. So pacemakers can be temporary or permanent. And let me clarify something. We're going to start this conversation in 3, and I'm going to tell you what's testable, okay? And I'm covering a lot of it. I'll cover it all. But we'll finish it in 4. So there might be some stuff up here that I'm going to go, this is great information, but you don't need to know it all yet. You ready? Okay. So we just said, I talked about a temporary pacemaker. There's also permanent pacemakers, and that's probably what you're so used to. That's what she was asking about. And that's what y'all are used to seeing and you know about. So we just talked about a transcutaneous, which is temporary, didn't we? Mm-hmm. The next one that's temporary, it can actually be temporary or permanent, is transvenous. And a permanent pacemaker is actually transvenous, where they are placing a little box under the skin. That's the generator box. And then they have little lead wires going through the veins straight into the heart. And it has corkscrew little sharp things on the end that embed into the heart muscle. All right? And they have to seat. Those little corkscrew things have to seat into the muscle. And that's why we will not allow someone who just had a permanent pacemaker placed to abduct. Like you abduct children. That's because y'all probably forgot, but I always do. This is abduct when you bring your arm up. Abduct, like you abduct a child. Isn't that horrible to say? But anyway, maybe you'll remember. And so, because if the little leads are not seated in the heart muscle where they get in there and they get hooked in real good, because at first, are they going to do that? Is it going to have time to get in there and heal around it and grow into it? Mm-mm. So we limit their activity of that arm, don't we? We tell them no pushing, no pulling, no abducting.
Permanently or?
No, just for a few weeks. Until it has time to do what?
Heal.
Heal and seat in there. Okay? And so you don't think about certain things with that. But let me help you think about certain things. I wish I had a big old busted person in here. Who's got some... She goes, don't look at me. No. I'm not going to do that. It might embarrass somebody. I'll use myself and y'all just laugh. If I had big old bosoms and I went to the cath lab and I laid like this and you seated the pacemaker right here in me, and then you go to get up, your big old bosoms are going to pull your chest and yank your pacer wires. Years ago, we didn't think about that. And we kept getting patients back from having a pacemaker, and they were not working. What the heck? And then we realized all the patients that this was happening to had big old boobies. And so then they started making the design of the pacemakers better And we started taping boobies better and doing a better job of managing those things and not allowing them to pull the wires out. So I tell you that so you'll remember how important that this is, that they don't need to be doing that. And that's one of the teaching things with a pacemaker. And teaching's one of those highly testable things that you've got to teach a patient if they have a permanent pacemaker.
Is that just the left arm? That's the
Well,
left.
let's talk about that. Sometimes, why do they put it on one side or the other? They can put it on either side. Most people are right hand dominant. So they're going to put it on the left because they know they'll be doing this with their right. Because you got to wipe your booty, you got to feed yourself. You know what I'm saying?
So it just depends.
It just depends,
Okay.
whichever side it's on. And so, again, you will have some people with the pacemaker on the other side, and there are other reasons they'll put them on the other side. You ready? And now this is a real, I mean, you don't have to write this. This is good information. When you have a PICC line placed, they thread that PICC line up just like they thread the pacemaker wires. Ha ha ha. So if you have a patient that needs a PICC line and they have a pacemaker, you need to let the PICC team know which side their pacemaker is, because they have to go on the opposite side. Now, if you have a patient that's had several PICC lines and several central lines, they may be scarred up on one side, so they're going to use the other side. That make sense? Okay, that's just extra from Miss Cooper. Thank me later, because when you get out in the clinical area, you'll see it applies. Okay? So now, so far, what do I want you to know? Pacemakers can be temporary or permanent. The temporary transvenous pacemaker is like the patient I was telling you about that we put on the transcutaneous pacemaker, and her heart rate didn't come up. And so it worked, but we can't keep them on it over 24 to 48 hours, because it's going to burn her. But she still needs it after 24 to 48 hours. This lady still needs a pacemaker. But we're really not sure what's going on. And we don't have anybody here at the moment to put a pacemaker in. So doctors are very skilled at, they can actually thread pacemaker wires through a central line straight into the heart. Remember I told you we would talk in level 4 about that Cadillac of a central line that can give you all those numbers in the ICU? Yeah. And I called it a Swan-Ganz catheter. Do y'all remember that? Mm-hmm. One of the ports on a Swan-Ganz says pacing, and you can actually take a wire and go straight through it and pace the heart. And we can put, it looks like a, any gamers in here, it looks like a control to a gaming station. Oh. That generator does in the ICU. And we can actually hook it right to that wire.
Wow.
Yeah. So there are different kinds of pacemakers, and all I want you to know is there's a transcutaneous one that we use in an emergency right there, because nurses can actually apply that. Okay? Trained nurses can apply that anywhere. And then there's transvenous temporary that is done by a skilled provider, not the nurse. Okay? And that patient's going to be in the ICU. And then there is a permanent pacemaker, which is the one you're used to seeing with the generator, little bleb under the skin that people go home with and live with for years and have to have batteries changed, and sometimes they're defective. Y'all know what I'm talking about? Yeah. Okay. And so with that, what I want you to know is you're supposed to learn the code to pacemakers, and I think this is ridiculous, but let me explain. When you get a device implanted in your body, such as a pacemaker, you get a card, identification card. This is the kind of device you have, and this is how it's programmed. And so the codes indicate how it is programmed. And in level 3, we teach you the first 3 codes, and there's 5 of them. The first three are the chamber paste. So what chamber? Is it the left ventricle? Is it the right ventricle? Is it both? You see where I'm going? Okay. The chamber sensed, which means where's the sensor at that's telling the pacemaker what it needs. What does the heart need? Chamber sensed. And then the response, or what kind of activity the pacemaker does based on what it picks up or it senses. That's all you have to know are those first three things: chamber paced, chamber sensed, and what it does in response to what it picked up or sensed. First three on up there. And where it says 5 codes, you just need to know the first three. Okay? So far, so good? Alright, so here is an example of one of those cards. And on the other side, or in the documentation, it's going to say a code. And I'll show you, but I don't want you to learn all that, those letters and stuff. But I want you to know there'll be a code that tells you those things. So now, patient teaching. Here's some of the patient teaching that's important. It's in your book, and you can read through it. So what do you think the pacemaker, I told you one of the complications that could occur would be they could actually, dislodge the leads from the heart, so they could mess it up by dislodging the leads. What do you think happens to older people with nasty little fingernails?
Infection.
Infection. Because they'll have a little incision from that little pocket that they put that generator in. And we put pacemakers a lot in older people because our sinus node poops out over the years. And so some of them will be confused even, and I'm like, oh Lord. And so trying to keep their hands, because it itches or it stings right after we put it in, so they'll be up there trying to get, what is this, off, and you're like, don't touch that. And so, do you get what I'm saying? Infection's a real issue, even with us. So one of the complications is infection. We tell them, and I think this is funny, I was like, I've never seen a tub this high. But I guess you could lay in your tub. Maybe some people lay in the tub. I don't lay in my poo-poo juice. So, either. But some people do. They soak in the tub, you know what I'm saying? So but old people like to take a bath. So I tell them, don't be laying up in the bath where your pacemaker incision is going to get wet. You can sit in the tub, but don't take your poo-poo rag from down here and wipe my pacemaker incision. Y'all laugh if y'all want to. You got to get down and dirty with people to make sure they understand you. Because I have been shocked going to the hospital and helping people into tubs and helping people into showers and see how they bathe. I was like, your mom didn't teach you to do your face first?
So many people go
They'll go cleaning this
all the time.
and this, and then they bring it back up here. I'm like, no. And so you got to teach people stuff that you didn't realize that they didn't know. And you wonder why their wounds get infected. Well, you didn't tell them they couldn't get in the tub with that big old slit in their foot. And so they sitting in there with their booty juice, and they get E. coli in their foot. I'm serious. And so you've got to teach people how they understand it, not fancy like you saying it. So anyway, site care and monitor is important, and you also have to tell people not to wear tight clothes over their pacemaker because it'll rub their incision, cause inflammation, and then infection. So all this stuff up here, you need to read through that and kind of start getting comfortable with that. Cell phones on the opposite ear. Here's the most important thing for you as a nurse with a pacemaker. They cannot have an MRI. They need to keep their card. They need to remind all providers that they have a pacemaker. I know some very young people in their 20s and 30s that have pacemakers. And something will happen to their back, and their doctor will just order them an MRI, not even knowing that they have a pacemaker. We have safety in radiology to make sure we don't do that, but what if we're human, we slipped? So we can really hurt someone because it can totally deprogram and make their pacemaker stop working, or it can try to pull it out of their chest. So no MRIs. So if an MRI is scheduled for a patient with a pacemaker, you're going to contact the healthcare provider, and you're not going to let them go. All right? Y'all remember that?
Yes.
Okay, so here's all the complications that can occur, with pacemaker insertion. The main two we talked about were infection and dislodgement. There are others, and this is the one you're responsible for other than infection and dislodgement. Loss of capture. And I'm going to show you what that is in just a minute. And I'm going to tell you what it means. When we use a pacemaker, any pacemaker, pacemakers in general, they are doing the work that the SA node typically does. And so it is sending out literal electricity through the pad. And you will see that it is your pacemaker is turned on by a spike on your EKG baseline. It'll just be look like a little ink mark. And I'm going to show it to you. Okay? We know the heart responds to that little spike when a QRS follows it. All right? And it is a QRS that does not look like the patient's normal QRS because it's coming from a different area. It's coming from an artificial source. So it's traveling a different way, which is going to make it a little bit wider and look different. There are other complications of pacemakers. There's one that can kill your patient. You think that's important to know?
Mm-hmm.
And you'll think it won't happen, and it will. And it's called cardiac tamponade. And just like a tampon, you shove it and it fits snug. Tamponade is just that. And where this is occurring, cardiac tamponade, what it means is the pericardial sac that surrounds your heart. Y'all know what I'm talking about?
Mm-hmm.
Typically in A&P you learn there's not much fluid in that sac. With tamponade and a pacemaker, what happened was that sac was insulted or kind of pierced, and bleeding occurs in it, and it gets tighter and tighter, and the sac just gets full of fluid, and it like a balloon, and it just gets tighter and tighter on the heart like this. And if something is tightening down on your heart, can it relax and contract and relax and contract? That can kill your patient. And so after a patient has a pacemaker placed, we have to make sure we did a good assessment before they went, listening to their heart sounds, knowing how strong they were, knowing what their baseline vital signs are, knowing if they had JVD or not. So what position, this is a test. What position do you put a patient in to check for JVD?
30 degrees.
30 to 45.
Awesome. You put the patient supine with their head up 30 to 45 degrees. Okay? You should know that. All right? So, but where, I'm sorry, I squirreled because it hit me that you needed to know that. And I realized a few semesters back, some people don't remember that. All right. So tamponade. I told you what it was, didn't I? How do we recognize it? Muffled heart sounds. Muffled heart sounds. Well, if you didn't know what the heart sounded like before you sent them, are you going to be able to recognize that it's muffled? Mm-hmm. So the other thing would be JVD. Are you ready with this? With clear breath sounds. JVD with clear breath sounds. And I hope that makes sense to you, because if the blood is trying to come into the right side of the heart, y'all remember the blood enters the right side of the heart from the superior and inferior vena cava? Mm-hmm. If it's trying to come in there and it can't, it's going to back up into the system from the heart. And so you're going to get JVD. And typically with JVD, you think right-sided heart failure, don't you? Yeah. And if they have right-sided, typically they have left-sided too, and so you're used to a big old wet lung with that, aren't you?
Yeah.
In this case, their lungs will be just like they were before you sent them. And it's weird. And so that's interesting to me. So you definitely need to know that cardiac tamponade can occur with a pacemaker. We think of cardiac tamponade with cabbage surgery because they're cutting into the heart. You know what I mean? And we think, oh, they're just going for a pacemaker. There's nothing to it. People do it all the time. I'll tell you, I've had people try to die on me after a pacemaker, and it ain't funny. And so when that happens, it's a medical emergency, and they've got to do a pericardial centesis. And that's where they take the needle, and you'll see it on Grey's Anatomy and all these doctor shows. And they go and take the needle right there and stab it in the chest. The blood spurts out. And they're like, oh, yay! You know, and you're like, yeah, we wish it was that good, orchestrated and good. It's more like, oh, my God, do you remember what we need to get? You know, we're trying to find everything. And sometimes when we try to do pericardial centesis in an emergency, it works, and sometimes we have to crack their chest. So anyway, it can happen. So cardiac tamponade, you need to know the signs and symptoms, and you need to recognize that it can occur after a pacemaker replacement. All right. So have I stressed those things enough? Now let me show you loss of capture. Remember I told you, you know a pacemaker's working when you see these, see the spike? All right, you see that right there you do not have capture. Do y'all see that? If your pacemaker is working, we set it at a certain rate. And the rate you set it at is how many spikes you're going to have in that 6-second strip when you're on your monitor when you're looking. And so it's working, but is it working consistently? No. So what's happened is we have lost capture. We are no longer have a current strong enough for the heart to consistently respond. Does that make sense? So sometimes we hook a pacemaker up. How you hook it up is you put the pads on, and there's a button that says turn it on. And then there's a button that you set the rate. The doctor tells you the rate. And if your sinus node does 60 to 100, where do you think we kind of set it? Between 60 and 100 based on what the doctor tells us. So we set it at 70. If we set it at 70, we should see 7 spikes, right? And then there's a current. It says current, and you have to we go up slowly. Current is electricity. So we go up slowly until we have capture. And capture means we have a QRS. See how it's kind of wide? That follows those spikes. And once we get capture, we dial up 2 to grow on because we're trying to prevent loss of capture. Does that make sense? But sometimes people are difficult. We're doing good. We got capture. We think our patient's all right. In the ICU, we get them off our floor and send them to the ICU. And the ICU nurse is kind of watching them close, and she goes, oh, I'm good. I can go get me something to drink. And she goes to get something to drink. She turns around, and that's what she sees. So she has loss of capture. So she has to go back to the bedside and increase the threshold. And what does that mean? The threshold is the amount of energy that it took to get capture in the beginning. So the amount of energy that it took to get capture in the beginning. So then she'll just have to juice them up. Does that make sense? A little bit higher until she has capture. And when she has capture, she'll have a QRS following every spike. Does that make sense? Because you can't understand loss of capture if you don't understand capture. Right? So here's the other pacemaker things that can happen, and I'm not even going to go over them because it'll just stress you out. Okay. We'll do that in level 4, all right? Okay. So here is a picture, and here's your pads, Christina. The pads are on the left. Those are the same pads that we shock with, that we pace with, and we can do something else with them. We can cardiovert through them, synchronized cardiovert through the same pads and the same shot box. This is a shot box that's like out in Ocean Springs Hospital or Sand River Hospital. But all of them, no matter the company, they pretty much do a lot of the same things, okay? At Sand River, the Pacer thing is right here. It's in hunter green, and it says Pacer, and that's the button you turn on to get the Pacer to come on. There's the rate button with the up and a down. There's the current button with an up and a down, and then there's a pause button. And the pause button we use when the doctor wants to see what the patient is doing on their own, such as that patient that took all those calcium channel blockers and beta blockers. If we had her on the temporary pacemaker for a while, set at a certain rate, the doctor's going to go, let's pause it and see if her natural rate is coming up any. And so you actually have to hold that button down, and then it'll turn it off temporary, and then you just release the button if the patient's not doing anything else. Okay? You don't have to remember that. I just like to share my knowledge with you to kind of tell you how these things work. Okay? Because this is the shot box, and that's how we turn it on to do like the AED mode. And we open the door, and we can do it in ACLS and do it all ourselves. It has a charge button, most all of them do, and then the red, that red button, when you hit it, what happens?
Shock them.
Ooh, and you if you touching them, or the bed. So you clearing with any kind of shock, whether it's synchronized cardioversion or just if you're defibrillating someone, you have to make sure you do what? Clear, and everybody else is clear. That's a big safety thing, and they test that on NCLEX constantly. Okay. I told you that transcutaneous pacing hurts, didn't I? Did I tell you it hurts?
Yeah.
So it's important that if the patient's stable enough, how do we know they're stable?
Their blood pressure is greater than 100 systolic.
Then we can give them some pain medicine. But if they're acting like they're almost down the drain, they ain't gonna feel it anyway. Okay? Are not awful. But we don't have time to give them pain medicine if they're swirling the drain. All right, here is, remember I told you that the transvenous, we hook it to a thing that looks like a little control device that you would play games with, I guess in my day. But this is what it looks like, that you're hooking the transvenous one, and it'll actually thread through a central line. Okay? All right. There's one more temporary pacemaker I want to introduce you to. If you ever are in the ICU, and you may get to go to the ICU this semester, and they have a heart that comes back, a heart meaning open heart surgery, they're going to have a big sternal incision, and below that incision, they're going to have something curled up on their chest or lower abdomen, or I said lower abdomen, upper abdomen, lower chest, and it looks like clear fishing line almost. Those are wires that are inserted directly into the heart. They're called epicardial pacemaker wires, and they're very temporary. And that is because this patient, and I don't know if you can, well, you sure can't see it now, but it's right here. You can't see it real good, but they will literally tape them to the chest in the event that the patient needs pacing. Because a common complication after heart surgery is bradycardias or arrhythmias. And so they just put them there. And the reason I tell you this every semester is because I've had patient families and students that tried to pick that off. You know how we'll take tape that's unneeded off of a patient? Do not take that tape off, because you can accidentally pull those wires or pull on those wires. Those are pacing wires, and they only keep them for about 24 to 48 hours, sometimes a little longer if the patient seems unstable. And to get them out, the nurse literally pulls them out. It's
Does it hurt them?
Huh?
Does that hurt him? Or they don't?
Not really. But there's a little danger to it, so don't you do it as a student.
Okay.
So nowadays, I was told, they have some that maybe dissolve, you know how they make sutures that dissolve? And they'll clip them at the chest, and so we don't have to pull them. We're evolving, y'all, it's awesome. But you still see a lot of them that we have to pull out, according to where you work, who your surgeon is. All right, so is it top of the hour yet? Okay, it's time for a break, guys.